All right. Well, hello everyone, and thank you for joining today's webinar. My name is Elaine Dalpiez, and I'm the Vice President of Governmental Affairs at the National Alliance for Caregiving. Most of you on this webinar know the National Alliance for Caregiving, but for those of you who don't, we focus on the health, wellness, and financial security of family caregivers through research, policy, and advocacy. We also lead the Caregiver Nation Coalition and the Caregiver Nation Network. I'd like to welcome the state advocates in our Caregiver Nation network, AARP state office staff, state affiliates of our Caregiver Nation Coalition, and all of the passionate caregiving advocates on this call. Today's webinar was organized because state advocates asked for it. You wanted to learn more about the Budget Reconciliation Act of 2025, or HR1, and its impact on family caregivers, and what state advocates can do to see that family caregivers do not lose their Medicaid coverage due to newly imposed work requirements. And special note, although the bill uses the term community engagement requirements, we will refer to them as work requirements during this webinar. And before we dive into the webinar, I want to say that we are grateful for the support of the John A. Hartford Foundation for making much of this work possible. So like all of you, we quickly shifted our efforts to implementation once HR1 passed. In November, we sent a letter to CMS raising our concern that work requirements could harm family caregivers, and we urged CMS to incorporate guidance to the states which supports the Raise Family Caregivers Act definition included in HR1. In December, we produced a toolkit that state advocates can use, which includes a template letter and other helpful information. And also in December, NAC participated in a listening session with CMS officials focused on data sources because caregivers are not usually identified. Just this week, we sent another letter from the Caregiver Nation Coalition to CMS, lifting up the various data sources that can be used to verify the work of family caregivers. Today, we will release a new checklist and a policy implementation recommendation list for your state outreach efforts. You should have everything that you need to get started or to keep working on your advocacy regarding work requirements and family caregivers. Next slide. Today's agenda will offer more information about the work requirements that states must implement. Our resources today and our speakers will inform you about who you should talk to at the state level. And of equal importance, you will learn what you should ask for. And as requested by state advocates, we have set aside time at the end of the webinar for sharing and collaboration. State advocates can share with each other what they are hearing in their states, what tactics others are using, etc. During today's webinar, we will drop advocacy tools and resources into the chat. We will also include all of these resources in one document after the webinar, so you will have easy access to everything you need. Everyone who registered for the webinar will receive them in our webinar summary email. I will walk through the highlights of HR1, and then our speakers will dive deeper on various pieces of the bill. Once the speakers are finished, we will have about 10 minutes for Q&A. So please drop your questions into the Q&A section of the chat along the way. And after Q&A, there will be roughly 15 to 20 minutes of time for advocates to share state Medicaid updates with others on the call. So please stay on the webinar to the end and share with each other and learn from one another. Next slide. Last July, Congress passed HR1, a tax and budget reconciliation bill that implemented work requirements on those receiving Medicaid subsidies as part of the Affordable Care Act. The law mandates work for most adults ages 19 to 64. And as for the 80 hours of a month of qualifying activities that Medicaid recipients must verify, it is unclear how that will be achieved or documented. We are awaiting CMS guidance for more clarity on that. States must also verify that enrollees either comply with the provision or are exempt. States must implement work requirements by January 1st of 2027, although they are allowed to start earlier if they choose to do so. We also hope that CMS would encourage the states to take a broader approach regarding the definition of family caregivers, but they have not done so. Basically, they are leaving it up to the individual states. Next slide. One of the best tools in our toolbox as caregiving advocates is the fact that Congress included the RAISE Act definition of family caregivers in HR1. The definition is inclusive and broad, not restrictive. This tells us that Congress was very concerned that family caregivers could unintentionally lose their coverage due to work requirements. And Natalie Keene will talk more in detail about this in her remarks. Next slide. As you begin to engage in advocacy, please utilize this treasure trove of rich data. The recent 2025 Caregiving in the U.S. report, which is a joint project between NAC and ARP, tells us that in the past 10 years, there has been nearly a 50% increase in the number of family caregivers in the United States, primarily driven by family members caring for older relatives. There are now 63 million caregivers in our country, which is nearly 1 in 4 Americans. Family caregivers help prevent the need for institutionalization, or they help delay the need for it. On average, caregivers spend 27 hours per week providing care, and nearly 1 in 4 provide 40 or more hours weekly, the equivalent of a full-time job. 30% of caregivers have provided care for 5 or more years. So whether caring for an adult child with a disability, or a spouse with cancer, or a parent with dementia, these caregivers now find themselves at risk of losing their health coverage because of new work requirements. Most Medicaid recipients are working, and those who don't work are either disabled, caregiving for others, or in school. And we know from Caregiving in the U.S. data that nearly 60% of all family caregivers work. So please refer to the Caregiving in the U.S. National Data Report and your individual state reports when looking for compelling data to use in your advocacy work. Next slide. Now on to our speakers. To allow more time for their remarks, we won't make formal introductions because their bios are in the webinar invitation. Today, we will hear from Jennifer Dexter, Vice President for Policy at the National Health Council. She will talk broadly about the pain points of implementing HR1 and the timeline for implementation. Natalie Keene is the Director of Federal Health Advocacy at Justice and Aging. Natalie will share what strategies some state advocates are using and give you ideas for what to ask your state officials for regarding policy implementation. Our third speaker is Brendan Flynn, Director of Long-Term Services and Supports at ARP's Public Policy Institute. Brendan will walk us through the various data sources so states can use to identify and verify family caregivers. And Tony Gingerelli, Director of Policy and Advocacy at NAC, who many of you already know, she will oversee the Q&A portion of the webinar and the time we have set aside for state advocates to share their updates. And now I will turn it over to Jennifer Dexter.
Thank you so much, Elaine. I'm very happy to be here today. For those of you that aren't familiar with the National Health Council, I'll just take 1 second to just say who we are. We are the umbrella organization for patient organizations and the patient voice. Our membership is made up of many of the very large to very small rare disease patient groups. We have a category of membership called Partners of Patient Organizations, of which NAC is one. We are very proud to have them in membership. And those are groups that are providers, caregiver groups, research groups, organizations like that. We also have a category of membership that's business and industry, but we are always majority led by the patient organization. So that's where we are. We can go to the next slide. Okay. And one more. This is the very, very high level time frame for the things that are coming. As Elaine mentioned, they had initial guidance of how these work requirements were going to be implemented in December. We are in a phase now where we are waiting for and preparing for an interim final rule that will come out in June that will have more standing, which is really the starting line for a lot of decisions that states have to make. States have to begin working to make sure that people are meeting these requirements as of January 1st, 2027. So it's coming up very quickly. And as Elaine mentioned, states can go earlier and several are right now. I know Nebraska was kind of first out of the line. Georgia already had a program running, so they are up and running. There are several states that have tried it in the past and run into roadblocks or legal challenges, who are kind of most likely to be some of the first out of the box as well. So time is short, but at the same time, there are a lot of decisions yet to be made, and that's my message to you today. Um, the guidance that went out to states was very broad, and the law itself provides states a lot of flexibility around how they define things, how they implement things, what they do. That is what we're all trying to figure out right now. The National Health Council has been working very closely with CMS and a lot of our patient organizations to try and figure out the best answer to some of the open questions that states are grappling with, including things like the technology they're going to use and how AI and other things can be used to hopefully help do this. I should say at the very beginning, we are very committed to making this work. It is something we opposed all along and fought very hard against. But now that it is law, the word of the day for us is mitigation. We want to work to make sure that the fewest people possible lose their coverage, even though we know it will be a significant number. But if we can mitigate some of that, I think that will be really important. So those are decisions that are moving to the state. And so we've been having a lot of conversations with CMS. We can go to the next slide. And the thing I wanted to touch on a bit is what are the decisions that are being made at the state level? And right now, we're asking CMS to provide as much guidance as possible, but very soon this is all going to be moving to the state level, and these are just decisions that state Medicaid offices and state legislatures are going to have to make. So these are, as Elaine said, some of the pain points we've talked about. So these are the things that we are working to do. We want to make sure that the potential for errors in adjudicating Medicaid eligibility are as few as possible. We know from when we had to, after COVID, unwind Medicaid, there are just a ton of things that happen between a law and somebody sitting around their kitchen table that can result in them, even if they've met all the requirements and done everything right, still losing their coverage. So making sure that states are as tight as possible in how they are implementing this, making sure that CMS is providing the greatest oversight possible, and making sure that education and outreach gets to people and is clear and actionable. We actually are encouraging them not to go beyond the scope of the law in terms of what they are requiring states to do. I kind of have said there are several buckets of states. There are those states who are going to, for good, bad, or indifferent reasons, whose goal is going to be to minimize their Medicaid rolls as much as possible. There are going to be states who just want to make sure everything is working the right way. And then there are going to be states who are going to be working within the confines of HR1 to make sure as many people stay on Medicaid as possible. So we want to make sure that the states are not, those states that want to have the most number of people, who are working to kind of be as broad as possible, have the flexibility to be able to do that they aren't required to have check-ins, have recertifications more often than what the law requires, those kinds of things. So I want to make clear that we're asking CMS to be as clear as possible on the exemption process. And this is one of the areas that Elaine was talking about where I think there is probably the most opportunity for impact. because the law states that people who are medically frail, people who are caregivers are exempt. Those definitions, especially the medically frail one, aren't like set in stone. They're still kind of struggling to figure that out. Even the caregiver issue, I think CMS and the states are all kind of trying to figure out not necessarily the definition, but how to identify and track and make that as easy as possible for people. So those are two areas where we're asking them to provide some good guidance. We don't want them being, you know, don't want it to come out badly, but we think there needs to be some predictability from state to state on those definitions, particularly. Um, Applying for the exemptions themselves, like one of the things that we've told people a lot is that um, community engagement work requirements, they there are ways a state could set that up where it could be as onerous as having to prove you've met the exemption could be as onerous as proving that you've met the requirements. So we want to make it as easy as possible for people to prove their exemption. So that will involve a lot of technology, a lot of what paperwork do you need? How do you submit that paperwork? All of that. Um, One of the things that, I used community engagement. I know Elaine said work requirements earlier, but I used community engagement because one of the things I want to make clear is that it's about work, but it's also the other ways you can meet those hourly requirements are through volunteerism, education, that kind of work. Well, that can be very difficult if that's how you're meeting your requirement. Volunteer programs aren't set up. They don't have a payroll system that you can just send your pay stub to. Like, how do we make sure that's all working? What kind of things count as community engagement? In our community, things like participating in support groups, doing mentoring, peer support, where does that all fit in here? So those are things we're looking for clarity on as well. Um, the next two are about education and outreach, making sure that information that comes from CMS and comes from the states is good, clear, actionable, and gets to people. And then making sure that CMS is monitoring implementation. This happened during the unwinding after COVID, where they put a pause on some states where their numbers got way out of whack in terms of the number of people that were losing coverage. Um, we are asking for a similar kind of monitoring and approach. So that is where we are. I'm put two, if you want a little more detail, why isn't it posting? Sorry. Okay, I just got to hit enter. Then these are two letters that we sent to CMS. The one in December outlines these pain points, and the one that we just sent a week or so ago is more detailed. We had an in-depth meeting with the team at CMS about some of our concerns and requests, and they requested more detail. They're very much in a point where they're trying to figure out. The example I use is they said, a caregiver for somebody under 14, for a child, states have those records. Like that's easy to check and prove. Other caregiver connections are harder for them to identify, for caregivers to approve or show. That is going to be a struggle for them. And so we're trying to work with them and NAC and others to make sure that we're getting good information to them about how that might work. So that's where we are. Elaine, I hope I covered everything you hoped I would. If there's anything I missed, let me know. But I appreciate the opportunity to share today.
All right, Natalie, would you like to go? And thank you, Jennifer. That was really helpful.
Yes. Hi, everyone. This is Natalie Keene with Justice and Aging. It's great to be here. I appreciate NAC for hosting this webinar and all of you for asking for it. I'm really excited that you're interested in engaging. Next slide, please. So I'm going to be talking about the more detail about the caregiver exemption and some advocacy strategies that you can use in your state. Next slide. This is just a little bit of background on justice and aging. For those of you who don't know us, we've been around for over 50 years, and our mission is to fight senior poverty by securing access to affordable health care, economic security, and the courts for older adults with limited resources. Next slide. So just as a threshold matter, Elaine laid this out and Jennifer spoke about it. It's important to keep in mind that not all Medicaid enrollees are subject to work requirements. There are multiple ways that a family caregiver who is enrolled in Medicaid for their own health coverage might be excluded or exempt from these work requirements. Two buckets here on this slide. The first is to remember that only family caregivers enrolled in Medicaid expansion are subject to work requirements. Medicaid expansion is the coverage pathway established under the Affordable Care Act to cover adults ages 19 to 64 with income up to 138% of the federal poverty level. So right now, that's 40 states and Washington, D.C. Adults in that same age group in Georgia and Wisconsin may also be subject to work requirements because Georgia and Wisconsin offer a similar type of coverage through a demonstration program. But that also means that caregivers living in 8 states, Alabama, Florida, Kansas, Mississippi, South Carolina, Tennessee, Texas, and Wyoming are currently not going to be subject to work requirements or have to worry about them right now. The second bucket on this list are exclusions or exemptions. The first are categorical exclusions, and this is the inverse of the first bullet. So if you're not in Medicaid expansion, then you are not subject to work requirements. So anyone who's under the age of 19 or over or age 65 or older, anyone who is enrolled in Medicare, anyone who is enrolled in SSI or SSDI, or anyone enrolled through any other Medicaid pathway. I saw a question in the comments about people who buy into Medicaid. That's an option available to people with disabilities. They are not subject to work requirements. And so the state should be automatically excluding these individuals from work requirements. They should not have to answer any questions about work or apply for any exemption or prove that they are exempt. The state should be automatically excluding them from consideration. The second sub-bullet here is for individual exemptions. And these are people who are enrolled in Medicaid expansion, but their circumstances qualify them for an exemption from having to report work or other activities. And this is where the family caregiver exemption comes in, and I'll be talking about that more in detail. And then just to note, there are some other short-term hardship exceptions that states can choose to implement. Next slide. So focusing again on the second type of exemption, and for caregivers in particular, the law provides an exemption for parents, guardians, caretaker relatives, or family caregivers of a dependent child age 13 or under, or of a disabled individual. And as Elaine noted, the law also defines family caregiver in this context using the RAISE Act definition, which goes well beyond caregivers for people with disabilities. So it includes assisting people with chronic or other health conditions, disabilities, or functional limitations. And we know from congressional record and things that Congress definitely intended for this caregiver exemption to apply to family caregivers of older adults and other people with chronic health conditions and functional limitations. Next slide. So shifting to our advocacy strategies. While we have the law, as Jennifer mentioned, there are still a lot of choices that both federal officials and states have to make about how they implement it. And now is the time to be contacting those decision makers. So who can you contact in your state? You can contact your state's Medicaid agency. You can contact the Medicaid Advisory Committee, and within that, there's something called the Beneficiary Advisory Council. These are, in some states, new advisory councils that states are required to have. That's a great avenue to raise concerns about implementation of work requirements. You can also look at other agencies and offices within your state. So, agencies and offices that focus on aging or disability, or maybe you even have an office that focuses on caregiving. I would also suggest reaching out to your governor and to state legislators as well. How do you reach out to them? You can write a letter, and NAC has a wonderful template that you can use that focuses on caregivers in particular. You can also look for public meetings or forums where you can voice your concerns, share stories, and ask questions. And then in terms of what to be sharing, stories and examples are one of the best ways to help policymakers understand who caregivers are and what they need to be doing to make sure that caregivers don't lose coverage. I'm going to walk through some specific recommendations that you can be making to your state officials, and also more ideas about asking to review draft materials. There are some states that already are proactively seeking feedback, asking advocates to look at draft notices and application materials. I know California and Colorado, for example, are doing this. And this is a really good opportunity to work in coalition with other Medicaid advocates in your state to provide feedback. Next slide. So here are some recommendations. Jennifer mentioned there are options that states have and decisions states have to make. And the biggest one is when are they going to implement? We are advocating to, ask your state to not implement prior to January 1st, 2027, when the law says that they have to implement. Also, ask your state to protect family caregivers and other Medicaid enrollees by not making things more difficult than they need to be. So the law requires reporting compliance with work requirements, or showing that you're exempt at least 1 month before coverage begins for new applicants, and at least at redeterminations and renewals. And those have to happen every 6 months for this population. States should really minimize the frequency and duration of these checks and not require people to show compliance for more than a month. Next slide. So in working with advocates reviewing materials, we've unfortunately seen some states are interpreting the caregiver exemption incorrectly or too narrowly. Sometimes their interpretation is leaving out family caregivers altogether. So this is really concerning, and it's important to be reading and using your gut and your expertise if something looks too narrow and like it's not inclusive of family caregivers to speak up and say so. So here are some do's and don'ts. We are recommending states use the Raise Family Caregivers Act definition. This is in the law for the work requirements exemption for caregivers. We are asking that states specify that caregivers of older adults are included in the definition. And states should be providing examples of what caregiving looks like. So, what are some examples of assistance with daily activities? In terms of what states should not do, is use language that limits or narrows the exemption. So the exemption is not limited to caring for a dependent or even a relative. So we've seen where some states are, describing, saying, a family caregiver of a dependent or relative. That's too narrow. The the law does not define caregiving in that way. Also, there is no requirement in the law about hours or a requirement that caregiving prevent paid employment in order to be eligible for this exemption. So again, at this point in the process, we're discouraging use of words like full-time to describe caregiving or caregiving that prevents work. Examples and public messaging should also be careful not to only talk about parents or child caregiving relationships. These examples should also focus on the full range of caregiving activities. So yes, hands-on care is caregiving. So thinking about giving examples like help with bathing, dressing, and eating, but also grocery shopping, transportation, medication reminders. All of these are caregiving and aren't necessarily hands-on. And as noted before, the RAISE definition does include caring for someone under a variety of circumstances. So not only for someone with a disability. We want to avoid having to provide sensitive information about the care recipient, like the care recipient's diagnosis. That care recipient is not the applicant or enrollee in this situation. Next slide. The process for how family caregivers access the exemption are really important as well. So we recommend that states accept self-declarations to verify eligibility for exemptions, and particularly for family caregivers. Most family caregivers are not in a database identified by name as a caregiver. So they will need to identify themselves. And so we're talking about states accepting what someone says on their application as sufficient information to verify that they are a caregiver. Also, we don't want states to be requiring caregivers to provide documentation of their caregiving. That's a slippery slope into asking about hours and things like that that we think are outside of the scope of what Congress intended this exemption to be. The second bullet here is states should not be using payroll data or evidence of work to deny someone eligibility for the caregiver exemption. Elaine said at the beginning, many family caregivers do also do paid work, and they should still be eligible for this exemption if they are caregiving and enrolled in Medicaid expansion. So family caregivers who are paid by Medicaid directly for care or who are employed elsewhere should be able to get this exemption, and the fact that they are employed should not interfere with that. And then many states, in fact, probably most states are going to be relying on vendors to implement all of this. And unfortunately, these vendors don't have a good track record. They can be problematic in missing things when verifying eligibility for Medicaid. And so it's really important, given the short time frame here, all of the system changes, all of the potential new data sources that are going to be coming in. It's so important for states to test their systems before they go live. And as part of this testing, it's also asking to review things as a potential user of these systems. And really here, leaning in on you have expertise as a caregiver. Do these questions make sense to you? Giving that kind of feedback to the state is really important. Using stories and examples, I'm going to say this again. Please share stories and examples with policymakers. We've heard from the Centers for Medicare and Medicaid Services and from states directly how helpful examples are. It can be really challenging to try to wordsmith, and you may not even have the opportunity to review policy language. So providing examples is a really proactive way to illustrate who the state should be thinking about. This example here is from an interview that KFF did with current Medicaid expansion enrollees. And this gentleman is 52 years old, and he said, I do self-work with Instacart because I get to pick and choose the days I'm able to work and dealing with my dad, getting in that nursing home, and also dealing with my mom now because she's getting into that phase where she's needing more doctor appointments. So this example illustrates someone who is a caregiver under the RAISE Act definition, but isn't calling himself that. Also, this person is working, but would benefit from the caregiver exemption in case his hours with Instacart are not enough in a given month. It would be simpler for him to be exempt. Next slide. Oh, I'm sorry. I think I'm a slide behind. The next slide. If we can skip ahead to advocacy strategy state legislation. All right. Sorry about that, everyone. So another strategy that's kind of a level up here is to work on, in coalition, to work on state legislation to put limits and protections into state law. So Nebraska Appleseed, here is an example. They worked with partners to introduce bills aimed at mitigating coverage loss, and I put links to those bills there that you can use as examples. They address things like prohibiting the state from implementing work requirements early, even though the state has already announced they are planning to implement early. The state legislature could say, no, you can't. They're, these bills also address things like collecting data to monitor how these work requirements are impacting people. And our colleagues in California are also working on legislation to protect Medicaid enrollees from improper coverage loss under HR1. So even in a state like California that's being a little more proactive to protect family caregivers, putting these protections into law can help ensure that your state does actually follows through and doesn't change its mind. On the flip side, some states like Missouri are trying to enact laws to force their state to implement early and require more red tape. So here, stories and examples are really necessary to illustrate why this is going to be harmful to family caregivers. Next slide. So finally, just leaving you with a couple of resources. The first from Justice and Aging is our toolkit that goes into more depth on the medically frail and other exemptions and protections that can benefit older adults and caregivers. And then the second is our overview of all the changes to Medicaid and Medicare coming down the pike, including how the law impacts access to home and community-based services. So there's certainly a lot to digest, and now I'm going to hand it over to Brendan.
Thank you so much, Natalie, and thanks to everyone for joining today. My name is Brendan Flynn, and I'm speaking from the AARP Public Policy Institute, here to discuss data sources available to help family caregivers maintain their coverage. And we will start on the next slide, maybe the one after that. Yes, this one, perfect, thank you. So one important piece of the upcoming work requirements is the provision within the statute that calls for states to use ex parte verification, also known as administrative verification, where possible. So under OBA's text, or HR1's text, states need to use reliable information they have access to for the purposes of verifying enrollees' compliance with the work requirements, including exemptions such as those for family caregivers. Of note, states are to use these sources to verify, where possible, compliance or exemption status without requiring any action from the enrollees themselves. In an ideal ex parte scenario for family caregivers, enrollees who are caregivers would more or less experience this as seamless continued Medicaid enrollment. Now, states have greater flexibility as to which data sources they use. In any case, however, greater use of ex parte methods can help reduce the number of family caregivers who need to take action themselves to demonstrate their exemption in order to maintain their Medicaid coverage. This approach can also help reduce the number of inappropriate procedural disenrollments. Next slide, please. I should note that the ex parte verification process idea is not new to Medicaid. States similarly were called to use ex parte where they could during the COVID-19 public health emergency unwinding of certain rules related to Medicaid. What is very new, however, is the use of ex parte in this context and for these populations covered for exemptions under the work requirements, including family caregivers. Like I said earlier, OBA doesn't mandate or forbid that states use any one particular data set or another. The law calls for the use of reliable information and indicates a role for federal HHS to provide guidance, which has been mentioned earlier. That guidance has not come out yet. Even so, however, states and advocates to states can still act now. In real time, states are considering and making both policy and operational decisions on all aspects of the OBA work requirements, including ex parte data sources, including which data sources to use as a policy question, but then also the operational realities of pursuing agreements to get those data. Next slide, please. So what data can we use for family caregivers for this purpose? In short, there's a lot of options out there. No one source that I'll discuss here will include every caregiver in your state. And I do want to echo Natalie's comment earlier, which is that many or even most caregivers may not appear in any of these records, but some probably will, and that is worth pursuing to help protect their coverage. Many of the data sources, including the ones on the slide here, exist within state government. Some of these may be in the same agency administering the work requirements, and some may be in other agencies. In many states, home and community-based services or HCBS applications and/or person-centered care plans identify family caregivers of HCBS enrollees. It could be possible for states to leverage these data, identify caregivers here who themselves also have Medicaid, and proactively consider them exempt from the work requirements. Similarly, many states have policies that allow family caregivers of Medicaid HCBS users to be paid as caregivers themselves. Similar to the care plan and other documents I just mentioned, this could also be a source for states to use to identify caregivers for the exemption. Taking a step away from Medicaid data, records may exist among grantees of Older Americans Act or OAA funds, such as state units on aging and area agencies on aging. In particular, there could be data from the National Family Caregiver Support Program or NFCSP that could help identify caregivers that states might be able to use for this purpose. One thing that I don't have listed here, but that is at the state level, is that a few states offer tax credits to family caregivers who care for older adults and others in their lives to help alleviate the financial challenges of care. States with these policies may be able to confirm and identify caregiver status through existing tax records among those claiming these tax credits. Similarly, states may be able to leverage SNAP program data and/or guardianship records to identify more caregivers. For guardianship records, for example, states could explore whether verified information in these records might help determine a family caregiver status among guardians who could then be exempt from the work requirements if they're on Medicaid. Next slide, please. Now, it's great that many of these data sources live in state government or close to state government. And it's also important to consider those that states do not house or have control over, as these could include caregivers that state sources may not be aware of. So managed care organizations, for example, often collect data on their enrollees' family caregivers. This includes plans that operate managed LTSS or managed long-term services and support plans for state Medicaid programs and for Medicare Advantage plans. With the right data agreements, states might be able to use these data to identify and exempt caregivers with Medicaid. Most states, including most states with Medicaid expansion, have what AARP calls CARE Act policies. CARE here stands for Caregiver Acknowledge, Record, and Enable Act, which in short calls for hospitals to record family caregivers for inpatient visits in their EHRs, and also keep them informed of discharge plans and offer training on any task they may need to perform, particularly more complex medical nursing tasks. Each state law and each state policy have its own flavor, but generally share these principles and most importantly include caregivers on EHRs. Similar to the health plans, this could be another place for states to make agreements and access caregiver data for this purpose. Other providers might have caregiver data in their records, such as adult day services providers, physicians, and/or home care agencies. Even nursing homes and other institutions might have these data, as we know the caregiving journey doesn't end just because somebody moves to a facility. This is much more ad hoc and individualized than some of the other examples that I mentioned here, but where possible, states could pursue and attain access to these. I also want to recognize that there's a few data sources that are really up to the federal government that might help here. In particular, data that could come from VA and from the Social Security Administration. The VA administers several programs that provide benefits and/or supports to family caregivers, and SSA allows certain beneficiaries to have what are known as representative payees. Now, these payees are not always caregivers or even individuals, but payee status could still serve as a proxy for those individuals who are payees as a proxy for caregiving and thus an exemption from the work requirements. Next slide, please. Now, what is common among each of the data sources that I mentioned is that they involve personal health information or personally identifiable information. And so because of that, it is essential that as states make decisions to pursue these and other data sources, they do so in a way that ensures data privacy, security, and compliance with HIPAA and other relevant policies that may be at play. And that these data are used for the specific purpose of identifying caregivers, matching them to Medicaid enrollment records, and exempting them from the work requirements. These are often complex tasks, and states and potential data partners will both need to engage in careful planning, agreement development, and execution of any data sharing. This alone is a reason for states not to impose the work requirements before the January 2027 date that had been mentioned. On the next slide, please. One note on artificial intelligence, AI, and technology. We know that states will probably use these for the purposes of OBA implementation, HR1 implementation, including the work requirements. Our response is that any such tools be reliable, evaluate for bias, include humans in the decision-making process, and most importantly, and you can see this in bold on the slide, ensure that no Medicaid enrollee, including those who are family caregivers, should be disenrolled or considered not exempt based solely on AI determinations. Next slide, please. So a couple of resources for from AARP for folks to review. These are also linked in the chat or will be soon if they are not already. One is a paper that my colleague Adam Hotto, who I believe is on the line, and I published a few weeks ago that covers all of the topics I mentioned today in further depth. There's also a lot of state fact sheets and data that detail Medicaid across state programs, and a letter that AARP sent to CMS back in November on OBA HR1 work requirements and family caregivers. AARP had advocated both with CMS and at the state level to clearly exempt family caregivers as defined in the Raise Family Caregivers Act from Medicaid community engagement requirements, and shared AARP's paper that I mentioned earlier and potential data sources that CMS and states can use to identify and verify family caregivers and exempt them from the work requirements. Next slide, please. I also want to just give a quick plug for AARP's caregiver resource page, aarp.org/caregiving. This is a little bit more general than some of the content that I shared before, but it's a really great one-stop shop for all of our family caregiver resources. And I just want to make sure that this group is aware of that and have access to the resources here. But with that, I will turn back and thank you again, everyone, and look forward to the discussion.
Thank you so much, Brendan, and thank you to all of our speakers today. So next, we're moving on to our question and answer portion of our webinar. We heard a lot from Natalie, Jennifer, Brendan, and Elaine about the current landscape and what's happening right now in terms of work requirements at the state level. But now is your opportunity to ask questions that you may have from what you've learned so far. So if you have any questions, please drop them in the Q&A section in the chat. So there's a separate chat, but there's also, if you see at the bottom of your screen, if there's a Q&A portion as well. Some of you have already dropped questions in there. We're going to spend about 10 minutes doing that. And then the rest of the webinar, we're going to turn things over to you all. We know that there's a lot of state advocates that are on the line right now, and we want to hear from all of you what's happening at the state level, and this can be a peer sharing opportunity. So with that, we're going to jump into our questions. So first, received a question from Nicole, who asked, are there any states working collaboratively so we could potentially create a single portal for caregivers to prove work eligibility? And I'll open that up to anyone who wants to respond.
I have not heard of that. I do think that the flexibility that states have is going to make that difficult because there are going to be even states with similar goals and processes will have differences that might not be aligned. In addition, the way the financing for Medicaid works, states are going to have very different goals on how they track, monitor, affect things. Medicaid is not the most cross-state collaborative program. It doesn't lend itself to that. So I think that makes a lot of sense. What more you might see is some regional getting together to do technology contracts. I think that's something that might happen is if you've got a vendor that's selling solutions to multiple states, you might see some collaboration regionally on that.
Fantastic. Thanks, Jennifer. Is there anything else, Brendan, Natalie, Elaine, that you want to add?
No, I think Jennifer said it perfectly.
Okay, great. We have one more question here. How does this apply to anyone who is enrolled in Medicaid who is blind or visually impaired?
I can answer that. So if someone is enrolled in Medicaid through a disability pathway, then they should be totally excluded from Medicaid work requirements. That includes if you are receiving Social Security, disability benefits, SSI, or otherwise enrolled through an aged and disabled pathway. And there are many, many different pathways. So, but there are some people with disabilities who might be awaiting a disability determination from Social Security who are enrolled in Medicaid expansion. They should be eligible for the what's termed medically frail exemption. It's not a useful or thoughtful term, but that is what it's called. And people who are blind are specifically noted as being exempt through that as well.
I think that leads to the very important question about that second definition. While the caregiver definition is so important to this community, that medically frail definition and where we land on where CMS lands and where your state lands on that are going to be very important. One of the things I spent many years in the disability community. I'm in the kind of patient advocacy community now. That is a perfect example of somebody who would never consider who the word medically frail would not connect them to. So if you got a letter from the state saying, you have to prove you're exempt. Here are the categories, and one of them is medically frail. Somebody who's blind, somebody not going to consider themselves in that category. So the wording is problematic.
Thank you so much, Natalie and Jennifer. So we're going to move on to our next question. And I think this is a good opportunity to mention some of the advocacy efforts that we've, as our individual organizations and as the Caregiver Nation Coalition, have engaged in. Someone asked, how receptive has CMS been in the conversations they've engaged in with advocates around providing more rigorous caregiver exemption guidance to states?
In my conversations with CMS, and Natalie and Brendan, correct me if you heard different, I think there is a real concern to get it right. I do think there is a desire to do that. But so much of this is rooted in this perception of waste, fraud, and abuse. And they are terrified of people coming out of the woodwork and using the caregiver exemption as a way to avoid the work requirement, for lack of a better description. We all know that that is not, reality or a good thing or whatever. But I do think that they are very interested in getting it right. And I don't know that they know yet how to get it right. That may be speaking a little bit out of turn. And which leads me to the kind of thought that the guidance we get out in June may not be as detailed as we like, which then talks about kicking the can to the states to making sure each state kind of gets it right. It's more complicated than it seems, and it is particularly complicated by the perception of that woodwork effect, that fraud issue. So.
Yeah, I agree. I think especially the folks who know the Medicaid program the best and have been working on it for years at CMS are trying to get it right. I think there might be some decisions both at the federal level and state level that are out of their hands. So it's really important to keep advocating at all levels.
Thank you so much. And one of the things that we'll share too in our summary email that's going to go out after this call with all these resources, so don't worry if you didn't grab anything in the chat, is also a letter from our Caregiver Nation Coalition signed by 40 members listing some of the potential data sources that can be used for these caregiver exemptions that were sent to CMS as well. I'm so happy to share that with each of you, just so you're aware. We received CMS let us know that they'll be reviewing that letter. Great. So we're going to ask one last question before we move on to the states. So this is actually two people sent in this question. So how likely do you think it is that CMS will accept self-attestation for caregivers? There's another question as well. That said, one of the leaders in California told them that their understanding is that the federal government will not accept self-attestation for renewals. Is that your understanding as well?
I think this is one of the biggest questions. We don't know where this is going to end up. And how directive the CMS is going to be. So CMS could give states the flexibility, and we would argue should, because that flexibility is in HR1. HR1 specifically talks about ex parte data, as Brendan mentioned, as well as allowing applicants to provide information on their application without further verification. So, we will continue to make that argument, but I think it will very likely be very widely across states and could be more directive from CMS.
I think CMS is getting a lot of pressure from states to allow them to use ex parte where they can. I was shocked when I was meeting with CMF staff and they were using those words in ways that were sounded good. But I think the likely outcome is that there is some flexibility that allows states to use ex parte approaches with certain parameters. That's what I think is where CMS is going to land. They're going to want to have some checks. You can't use ex parte if, XYZ. That is my guess, is that they will retain that flexibility, but they will try and make it a little bit hard.
Great. Thank you so much, Jennifer and Natalie. And I do have one more question because I think it's important to address in the chat. There are some questions about privacy for some of these data sources and how we're thinking about that. This might be a good question for you, Brendan, but Jennifer, Natalie, Elaine, feel free to hop in because I know we've been having a lot of conversations about that. How are we thinking about privacy when it comes to these data sources?
Well, and that's why I think as states and potential data partners start to, have discussions around data, like that's why these data agreements are so important, because they, when done correctly, can clearly delineate, what data are being shared and what specific purpose those data are being used for. And so it's really important that when states are pursuing these, that they're very careful in how they're written to make sure that, all of those privacy concerns are addressed in writing from the beginning, so that there aren't any situations where someone's PHI or PII is becomes known or becomes inappropriately used. So it really comes down to those agreements, and it's why those agreements are so important to be done thoughtfully.
Brendan, I really appreciated your AI kind of framework, because I think I have seen, and I know there is a booming industry around using AI and technology advances to help states with this. And I think there's going to be a lot of good and there's going to be a lot of bad.
Yep.
And that's where a lot of the advocates come in. I think both on the privacy issue and making sure you're talking to state offices and state legislators around what's the check on that as you implement technology solutions, but also the usability of it all. Where, how does it work for patients? I think there's nobody better to test, advise, be that human in the loop at some level. And that's another place to really engage.
Absolutely.
And I'll just add, I think it's another place to, again, put in the plug for why self-attestation, self-verification is needed, at least as things are getting started, because it's going to take time for states to properly and securely, incorporate new data sources into their systems. And it is very sensitive. So, making sure that that there's a pathway still to get these exemptions and before those data systems are ready.
Absolutely. Well, thank you, Brendan, Jennifer, Natalie. We are going to move on to the state sharing section. For those of you who didn't have your question answered, don't worry. We're going to have our contact information on the final slide to reach out to Elaine and I, and we can connect you with anyone who you need to speak to or have a question for. In addition, I received a lot of questions about the slides. They missed important information. We'll be sending copies of the slides as well in our summary email. So with that, we're moving into our state sharing section. And because there are so many people on the call and we only have a few minutes left, feel free to drop any state Medicaid updates into the chat for everyone to see. Let us know what action you're taking in your state as advocates, what's happening on the ground. And if you want to speak, just raise your hand and we will call on you. Please try to limit your verbal comments to 1 minute so that we can hear from as many people as possible. With that, raise your hand and we'd love to continue the discussion in the chat. Okay, Michael, I see your hands up.
Hey, folks. Well, I appreciate all of this. This webinar has been incredibly helpful, for us that are, out here working in some of the different states. And one of the things I'll mention, this has been one of our priorities over the last year or so here in New Hampshire. And actually, I forgot to introduce myself at the top. My name is Mike Badmore. I'm the Director of Advocacy for AARP New Hampshire. And so this has been one of the things we've been working on over the course of really the last year or so since the One Big Beautiful Act was passed. And without diving too much into it, I think that one of the things that I'll mention, and I'm sure a lot of states are encountering this, that our legislative session runs from January until June. And so considering that the guidance, is coming out in June, I think one of the things that we're sort of struggling with as advocates, but also we're seeing the lawmakers really struggle with this as well. How do they implement this when there is uncertainty around what is going to be this final guidance that's going to come out? And so I'll just kind of add that. And the last thing I'll say is the caregiving piece. That's one of the things that we're really trying to emphasize here in New Hampshire is just ensuring that however this is implemented in New Hampshire, we want to make sure that that is very clear that caregivers do have that exemption. And I'll wrap up my comments with that.
Thank you so much for sharing, Michael. All really important things to think about, especially thinking through the legislative session timeline too. Would anyone else like to share? And panelists too, feel free to jump in if there's anything you'd like to add or comments that resonate with you. I also know we have a lot of advocates from the National Alliance for Caregiving's Caregiver Nation State Network. We work with 14 states across the country who have coalitions that are doing work to better support family caregivers at the state and federal level. So we'd love to hear from folks. Okay.
I'd be curious if there are any folks on the line from Georgia, where they've already implemented some of these, and if there's any information to share, may or may not be, that we didn't touch on.
Yeah, that's a great thought, Jennifer. Anyone from Georgia on the line who'd like to share? Okay, we see a note from Karen in the chat that I'll highlight. So Karen is a part of the North Carolina Caregiving Collaborative and is working on an advocacy letter. And the North Carolina Coalition on Aging has already sent a letter to the North Carolina DHHS Secretary, Deputy Director of North Carolina's Medicaid office, and Governor Stein's office. Thank you so much, Karen. And I believe Karen used the toolkit that was created by our Caregiver Nation Coalition. And in there, we also have a resource to help you find your Medicaid state director as well as your governor, just contact information. So again, we dropped that in the chat and it'll be in the summary email. So thank you so much, Karen.
But just seeing
there's
that reminded me that that is a state with where we've seen a drawback of home community-based services. And as important as all of this implementation is with the individual Medicaid recipients, it's also very important to look at your state Medicaid system and what the ripple effects are of budget cuts, of all of those things, and just still generally fighting for the health of the system, because it doesn't do us any good to keep people enrolled if they're losing access to services. So just a thought.
Yeah, Jennifer, that's a great point, for sure. And I was going to ask if there's somebody still on from Pennsylvania. I'd love to hear an update on that state as well. Okay, I guess not.
Yeah, and if there is no one else that wants to speak, Brendan, I know you put something in the chat about caregiving in the US, but there was a question earlier about the number of family caregivers that would possibly be impacted. Did you want to talk a little bit more about that?
Yeah, absolutely. Thank you. So caregiving in the US it was mentioned in the beginning of the presentation, is a joint NAC AARP product. and identified the most recent report that there's about 63 million family caregivers who care for adults or children with a medical condition or disability. About 7.3 million of them are under the age of 65 and rely on Medicaid for their own health coverage. A couple of important things. Not all of these are Medicaid expansion enrollees or live in a state with any Medicaid expansion. So it's not as though 7.3 million people could be affected by this, but that is, a pretty close, reasonable estimate. And so I would say that's a number to at least start with in terms of the number of family caregivers who are under 65 and have Medicaid as their coverage. It's about 7.3 million.
Great. Thanks so much, Brendan. It's a large number, and it's part of the reason that we're doing this
Absolutely.
webinar right now, because we want to try to mitigate as much as possible. Great. With that, as we wrap up, I'm going to pass things off to my colleague Elaine, but wanted to thank you all for attending. We know from our registration numbers that many of you are family caregivers or working in the healthcare space, economic security space right now. We know it's a very, very challenging time with lots happening. So we appreciate you taking the time out of your busy schedules to be here with all of us today. So with that, I'll pass it back to you, Elaine.
Okay, well, thank you. Thank you to our speakers. Thank you, Tony, for facilitating the discussion. And really, thanks to all of you for joining today. I would just say in closing, we need your voices now more than ever at the state level. So all of the resources that we put in the chat today are going out to you in a post-webinar email. So again, thanks for joining, and please stay in touch with Tony and myself as you have updates, because then we can share them with other states. It's so helpful. So have a great day and keep up the good fight. Thanks.